We're going to have a 10-minute question session and answer session. I would like to invite the last three speakers to the podium. I also want to say that the members of the audience are also free to answer some of the questions, although the questions will be directed to the speakers, Dr. Markel, Dr. Roshan, Dr. Yaniv, and Dr. Suresh. You're also welcome to answer some of the questions. Thank you.
We have a question from an online audience.
So I will now I'll now invite the audience to ask their questions.
Okay. Marjorie has a question. What's the benefit to keeping patient on immunosuppressant drugs after rejection?
So the question is, what's the benefit of keeping a patient on immunosuppressive agents after rejection?
Yes.
So actually, it's even more important to have the patients on immunosuppressive agents and to optimize the immunosuppressive agents. So for example, making sure that the tacrolimus levels are at goal, maximizing the most effective tolerable mycophenolate dose, as well as we will need to add steroids back on, because this is one, to prevent future episodes of rejection, because every episode of rejection can cause increase in graft damage. And remember, one of the first slides that I talked about in terms of acute and chronic rejection, it can lead to graft loss as well. And we need to do everything that we can to prevent that.
Yeah, and if I can say also, I think the question might also be touching. Sometimes we have patients who lose their graft, go back on dialysis, and they're still a little bit on some immunosuppression medication. And there's not a lot of benefit to the graft, of course, for that. But usually you want to taper that slowly over time so that the patient sort of slowly scars the kidney that has failed, as opposed to acutely really reject it. It's symptomatic and they need to go to surgery to remove it. So there's no long-term benefit when the graft is lost to keeping a patient on immunosuppression, but there's a benefit in slowly taking it away so that the body slowly scars it. It's supposed to acutely rejects it, and there's lots of symptoms. There's also, for the tissue typing lab, if that happens, there can be very significant antibody creation that then makes it hard to retransplant the patient later. So there's a few reasons why when a patient loses their kidney and goes back to dialysis, you also taper those medications slowly. It is important to always have this patient. What happens sometimes, though, is the patients go back to dialysis, forgets about their transplant center, and stays on these medications for a long time for no reason. So if a patient is on dialysis and those medications, it's important to still be in contact with the dialysis center to make sure that there's a plan to take them away.
Thank you.
Hi, how are you? Quick question about diabetes management. So for patients who have ESRD secondary to, issues with their diabetes, do you have a certain hemoglobin A1C that you want the patient to have, and for how long do they have to have it in order to qualify for transplant?
I want to say that we have a session on diabetes, so we'll probably take that question when we get to that session. We want to focus on infection on the current topics. Thank you.
Hi, just wondering the side effects of kidney problems, because I've known this gentleman who is a patient right here at Downstate, surely coming for blood transfusion, but the legs from the hip all the way down, it's very, very black, hard and scaly, just look like a big piece of log. So I'm just wondering, I have been wondering, I didn't want to ask as to, why is it the effects that the kidney problem that he's having, why it's affected his limbs like this?
I think that this session is, we are focused on from listing to transplant and on transplant medications. Your question is important, but you could ask me or Dr. Markel, or we could meet you after the session and then we would provide answers to them, but that will not be the focus of our program.
I'll go for the next question. Yeah, that's exactly what I wanted to say. It's probably, we can discuss this offline from the session. I have a question for you, Susan and Maxine. What is the single most thing that would change your time from a referral to getting listed, what is the thing you would do that would make patient get listed as soon as possible?
If we could get a patient referred to us with recent cardiac testing done and 2728 form, we could probably list them that week if they qualify. What's that?
Health maintenance gets up.
Yeah, and all of their health maintenance up to date, right? But we can list them with health maintenance, like their cancer screening out of date, we would list them as inactive until that became up to date. But in order to determine if they're a candidate, we'll need an echocardiogram, a stress test if it's warranted, and a 2728 if they're on dialysis. And everything else can be done. We can list them, and everything else could be done while they're inactive,
Well,
for the most part.
for me, what I would change is how we do things here. If I could get more facilitation.
Like,
Oh, can you hear me? Oh, for me as a coordinator, if I could get more department to work with me to get patient testing, that would benefit the patient even more, because our hospital has limited resources, as many people know. Oftentimes we may have to take patients, send them outside, but we're working on that to get other departments to work better with us.
So you're saying that delay in testing
Delaying.
is one of the major factors that
And I think this is why Susie said if they come with their testing, if they come with their test, if they come with testing from outside, it makes it a lot easier for them. And one of the major one is cardiovascular. If they come with their echo, their stress, it makes it a lot easier for us to move the process along for them.
Thank you. Yeah, transplant is a multidisciplinary field, and we rely on other departments like cardiology, GI, to get our patient worked up for transplant. And what they are saying is that the greatest impediment to a timely completion of patients' workup is these testings. Is that correct, Maxine and Susan?
Yes.
Okay. Do we have another question? No. Okay. I don't have any question online. Thank you, Jane, Susan, and Maxie, for this excellent presentation. Can we give them a round of applause?